Good evening and welcome to the 2023 January edition of our webinar series, The Cornea and Vitamin A, a New Perspective with Dr. Mohammad Dastjerdi from Rutgers, New Jersey Medical School. All participants will be muted throughout the webinar, but please do ask questions. You can ask them throughout the talk by entering into the Q&A panel, and they'll be answered at the conclusion. Dr. Dastjerdi also has some cases that you can feel free to put ideas or thoughts into the chat or the Q&A panel towards the end of the talk. Everybody make sure to register for next month's webinar. We'll have a slightly different format for that. We'll have a panel of Eversight research grant recipients who will update us on the work they're doing to advance medical and surgical cornea treatment. And as always, this webinar, like all of our webinars, will be recorded and available on demand at eversightvision.org/webinars. So now I'll just briefly introduce our speaker for tonight. Dr. Dastjerdi is an ophthalmologist and assistant professor at Rutgers, New Jersey Medical School. His specialty training is in cornea, external disease, and refractive surgery. Dr. Dastjerdi earned his medical degree from Tehran University of Medical Sciences and completed ophthalmology residency at Kansas University Medical Center. He finished a clinical fellowship in cornea external disease at Kellogg Eye Center, University of Michigan, and completed a research fellowship at Harvard's Schepens Eye Research Institute and Mass Eye and Ear Infirmary. And that's it for me. I'll turn the floor over to you, Dr. Dastjerdi.
Okay, thank you so much for the introduction. Good evening, everybody. And I'm going to start with my first slide. There's no financial interest here for me. So as everybody knows, I'm going to go over the basics quickly. Vitamin A is a fat-soluble vitamin, and it's abundantly found in milk, liver, meat, and eggs, and also as a provitamin found in green leafy vegetables. So most of our basically our basic foods has vitamin A either as an active form or as a provitamin. And the one thing that I just want to emphasize here, after absorption of the vitamin A to our body, it goes directly to the liver, and also it stores in liver. 95% of the vitamin A basically stores in liver. And based on the size of the body, the health of the liver, this storage, if it's completely basically full with the vitamin A, it can be something enough for 6 months to 2 years supply. So the reason that I'm emphasizing on this liver storage for vitamin A, and it can be variable from one person to other person because it's relevant clinically, and I will come back again to this. And also vitamin A basically it attached to retinol binding protein. It can then it's transported to the target tissue, and so that retinol binding protein also is a protein, and protein deficiency can affect the availability of the RBP. Also, the other thing that also may affect the production of RBP is zinc. Zinc deficiency basically can depress the hepatic synthesis of RBP. Also, zinc has a role in conversion of previtamin A or beta carotene to retinol through the enzymes. So people that they have some basically nutritional deficiency, also because of the vitamin A deficiency by itself, also because of the protein deficiency and zinc deficiency, it may aggravate it further. So as I mentioned, Liver stores 80 to 90 or even to 95% of body's vitamin A. And a small amount also can be in other tissue, adipose tissue, spleen, kidneys, and pancreas. And overall, our body has a limited capacity to store vitamin A. And this is very important that we should maintain a consistent intake of vitamin A to replace this storage basically and have enough reserve in our body. So why vitamin A is important? As all know, it's the precursor for visual pigments, rhodopsin in rods and cones. Also, it promotes growth and development of epithelial cells. That's very important in terms of the cornea standpoint. And also it's regulate gene expression and to control basically growth and differentiation of cells, particularly epithelial cells. And the main thing in terms of the cornea, vitamin A is required for normal differentiation of mucus secreting epithelium. And in vitamin A deficiency, basically mucosal epithelium in many organs can go under changes and it becomes keratinized, and we call it keratinizing metaplasia. And actually, eye is the most obvious and dramatic example of this process, and particularly cornea. So with vitamin A deficiency, we have different ocular manifestation. And it depends on the gradual deterioration of the vitamin A level in the body. We may have different presentation of this signs and symptoms. And WHO actually has a grading system for xerophtalmia. Xerophtalmia is the term that overall they used it as everything that happened to the eye because of the vitamin A deficiency. And if we look at the grading system of the WHO, it's somehow it organized based on the level of the vitamin A deficiency. And I'm going to go over the things. So as we go from night blindness to for example, to keratomalacia, it means that the vitamin A deficiency is much more severe. So night blindness is the most and earliest symptoms that happens in the vitamin A deficiency. And as we know, that is because of the lack of rhodopsin, and particularly in the rods, that it causes difficulty seeing in low light conditions. And these things can be basically reported mainly in teenagers and young adults. In kids and in elderly people, they may not report it, although we can prove it with the electrophysiology tests. And then the second level of changes is conjunctival xerosis. Xerosis overall means dryness of the tissues, basically. And the things that happen in the conjunctiva, basically, it goes through squamous metaplasia and keratinization. Goblet cells basically disappeared. And then because of the lack of mucin, we have a tear film instability. And all this causes the dryness of the conjunctiva. Also, the tear production, the aqueous tear production might be adequate and Schirmer test might be normal at this stage. But because of the lack of mucin, the tear film is quite unstable. And here you see a patch of, we call it xerosis. And it's and basically it shows some kind of a keratinization, and that shiny appearance tells us this area keratinized. And then it goes a little bit further. And if we see a patch of triangular patch of conj in temporal conjunctiva with this xerotic appearance, and then foamy substances appear on that surface, then we call it beta spots. And I can show you here again is a patch of conj xerosis, but then you see a little bit of foamy stuff there. And this is classic beta spot. I can show you more picture of this. You see that foamy appearance. And another one. And when we look at it under the microscope, basically, we see the keratinization and absence of goblet cells. And those foamy substances in the surface basically is a discarnated keratinized epithelial cells combined with some saprophytic bacteria, particularly diphtheroids. Also, at this stage, clinically, we see that patch in the temporal side. But if we look at the conjunctiva, entire conjunctiva, histologically, the entire conjunctiva basically undergone some basically keratinizing metaplasia, and the goblet cells decrease significantly. And as we go further down on the level of the vitamin A, then we may see more of the conjunctiva clinically become involved. Initially is in temporal, then we may see it in nasal, inferior, and superior quadrant, interestingly, is the last quadrant that get involved. And at this stage, the conj is become thickened, and it's resembles skin or shiny. You see that shiny appearance is become a thick, leathery, shiny tissue, and even with the naked eye, we can see it and recognize it. And here, this is the cornea also involved, but I'm going to show you that you see, if you look at the inferior conjunctiva, it may be more obvious in temporal or nasal, but at this stage, sometimes the best place to look in for conj xerosis is the inferior conjunctiva. Then the next stage is corneal xerosis. As the level of the vitamin A decreases further down, then we have changes on the cornea, and we see initially fine puncted keratopathy. Again, in infranasal, more concentrated, and then it can spread to entire cornea. Even although clinically we need to stain, but if we look for the, even in the earliest stage in the conj xerosis, we may see corneal staining and keratopathy, even a very early stage in 60% of those patients. So we can separate them and kind of clear cut stage them. This can be appear simultaneously. And here you see that initial puncted keratopathy on the cornea. And as we go further, the cornea also become significantly dry, and the density of the puncted epitheliopathy increases. And again, at this stage, with naked eye, we may see that kind of dry, hazy appearance of the cornea, and basically the cornea loses is a normal luster. And the cornea is also the epithelium of the cornea become keratinized, and we see that kind of shiny appearance on the cornea. And here you see that when we look at the cornea, we see that shiny appearance. Here another picture. We see that probably this area of the cornea is more puncted epitheliopathy, but this area is densely keratinized and is very shiny. basically these changes that happens in the conj and the cornea is the direct consequences of basically vitamin A metabolism and differentiation on the epithelial cells. And that's the things that I initially said, that the eye is the best example of that impairs cellular differentiation that can happen in all epithelial cells, but the eye is very, very obvious area that we can see this. But interestingly, if we diagnose them and start the treatment, systemic vitamin A treatment, within 2 to 4 days, we see that some of this puncted keratopathy start improving. And within 1 or 2 weeks, actually this kind of xerosis and that shiny appearance disappears. And I'm going to show you this in one of my own patients, that how quickly they respond to the treatment. Also, as I mentioned, aqueous tear production falls in xerophthalmia. Although in the beginning, the Schirmer test may be normal, but as the disease advances, even the tear production get affected, and also loss of goblet cells causes significant mucus deficiency. And but when we start the treatment, the corneal changes disappear much earlier before we have the reappearance of the goblet cells. And sometimes some studies, they look at the goblet cells, and it took for a long, long time that they come back to the normal level. And even some people, they said in the area of the beta spot, they never reappeared in that area for some reason, even with replenishing, full replenishment of the vitamin A. So, and then the next grade, as we go further and we have more and more severe form of the vitamin A deficiency, then we have the ulcer appears on the cornea. And the classic one is a small round punched out craters, or sometimes even full thickness perforation, but they looks like very sharp and round shape that it looks like we put a trephine and we trephine them. And that's one of the things. Also, I will show you some cases that is not the case all the time, but the classic form that they described in the literature is like this. And most of the time in the beginning, they are more peripheral, and again, it's more inferior and nasal quadrants. Again, in the cornea, nasal and inferior cornea is more involved. In conjunctival, temporal is the classic location for beta spot, and then inferior conj and nasal conjunctival. And superior conj is the last portion that get involved. And here you see in the left picture, you see a small ulcer, very deep ulcer. Although you see, you don't see that much infiltration. So it tells us this is a non-infectious ulcer. And here we have a much larger, and we have, again, it looks like we punched this area, but because of this motocell is basically impending perforation or already perforated. And the next step of the damage to the cornea is the irreversible loss of corneal tissue. And some of the collagens and the stromal corneal tissue get lost. And this is the worst, basically, condition and stage of the disease. And in the beginning, because of the ulceration, the epithelium gone, and then releasing of the collagenase, and it caused significant stromal liquefactive necrosis and desmatocell and perforation. And this is sometimes that at this stage, it's basically it's late to diagnose this condition. So Overall, vitamin A deficiency is very rare in developed countries and more common seen in developing countries where malnutrition is very prevalent. A little bit of historical perspective. The one thing that it was, reported very basically and as an epidemic, it was during the United States Civil War and also World War I. And they found that it can be cured by cod liver oil. And interestingly, during the Civil War, it caused significant vitamin A deficiency in soldiers, resulting in several ocular pathologies, and some of the troops reported night blindness, and eventually some of them got the keratomalacia, corneal ulceration, perforation, and eventually those people that they get the perforated cornea, most of them died within 2 weeks. From the historical perspective, some of this, when they reported night blindness, most of the time they consider that they are malingering. But there is an article published that they showed that reported about 8,000 cases of night blindness. And then, again, there was a difference between the white and black soldiers, 4.3 and 11 respectively in 1,000 troops in white and black. And they reported 30 cases of keratomalacia, that these 30 cases basically they reported die within 2 weeks of the keratomalacia and perforation. So the most important thing from the overall global health, vitamin A deficiency is one of the 4 leading causes of preventable blindness after cataract, glaucoma, or onchocerciasis. So it still is a big issue worldwide. And based on the WHO, about 250 million preschool children suffer from vitamin A deficiency. And about 1/4 to 500,000 child every year become blind because of the vitamin A deficiency. The other point is that half of these children, because of the blindness of vitamin A blindness, they die within 1 year of their life, half of these children. So it's quite significant worldwide. So in those countries, the most common cause of vitamin A deficiency is insufficient nutrition. And plus, although the nutrition is insufficient, also some coexisting other infection and other diseases also basically become more complex because of those diseases, we need more demand for vitamin A. And for example, in measles is one of those diseases because it affected the epithelial cells of the bronchioles and all those cells in the lung. It needs more vitamin A. And so if a patient has a measles and has not enough nutritional vitamin A, it becomes more severe form of vitamin A deficiency. And also other GI infection and diarrhea also aggravate the condition. But in the developed world, the story is different. Most of the cases basically is associated with the pancreatic or liver or intestinal pathology. Basically in the United States, mainly it's because poor dietary intake or malabsorption because of alcoholic cirrhosis or cystic fibrosis or inflammatory bowel disease, or sometimes because of the gastric bypass surgery for basically obesity. And people that they have severe form of diet, we may see this vitamin A deficiency. But one thing that I want to emphasize here is alcoholism and liver disease. Actually, alcoholism has much more effect on vitamin A deficiency. And the reason for that, because, for three different reasons. The vitamin A, alcoholism is people that they consume too much alcohol. They have a poor dietary intake from nutritional food, and then alcohol also interferes with the absorption and metabolism of vitamin A, and besides, because it damages the liver, the storage of the, there is no place for the vitamin A to get stored, and that's the problem. So, for that reason, alcoholic cirrhosis is more associated with vitamin A deficiency than any other etiologies, such as viral associated cirrhosis or other hepatic diseases. So patients with alcoholism, we need to be more careful when we are evaluating for, ocular surface disease. So as I mentioned, alcohol consumption can cause damage to the liver, which is the main organ responsible for restoring vitamin A. The liver damage caused by alcohol can lead to the reduced ability to store vitamin A, leading to much lower vitamin A level in the body. For example, a patient that I mentioned that, a normal liver in a normal person, and if it's, all the storage filled with the vitamin A, probably it might be enough for up to 2 years. But a person with alcoholic liver disease, the storage capacity of the liver has decreased significantly because, many cells already damaged. And they may not have enough, even up to 3 to, or 6 months of storage. And also, alcohol can damage intestinal epithelial cells. It can damage any, basically, in the GI tract, we can have other things. So particularly intestinal epithelial cell can be damaged, and that also can affect the absorption of fat-soluble vitamins, and also reduced bar that associated with the liver disease also aggravate the malabsorption of fat-soluble vitamins. And the main other factor is that the alcoholics often have a poor appetite. Their diet is not adequate with, food like eggs, dairy products, or, leafy vegetables. And also alcoholics has other nutritional deficiency and vitamin deficiency like vitamin B1, B12, folic acid, and zinc. So here, I want to, present some of the cases, and you can stop me. This case, after this case, also I'm going to come back with a few more slides, and then I'm going to present more cases. This case, I'm going to go more details. So this is a 2.5-month-old boy referred for corneal ulceration and perforation. And this boy basically, the mucus, his mother basically reported that he had some mucus in his eye that initially they treated, they thought that is a nasolacrimal duct obstruction. And then before presentation to us, mother mentioned that 2 days ago, I noticed a white spot in the right eye, and I tried to remove it from his eye, but I was not able. The parents and siblings are healthy, and the patient lives at home, basically with mom and dad and 3 siblings, no exposure to daycare, and they deny insecurity obtaining food or housing. And this is the examination under anesthesia, and this is the surgical view. This is the right eye that perforated, and this is the left eye. Also, you see that area of the perforation, but also you see there's xerosis inferiorly there. But look at the left eye. Also, we see a significant conj xerosis. You see that shiny, leathery, shiny appearance of the conj, particularly inferior conjunctival. And look at the cornea. You can see that the same thing, shiny appearance. And then this is the ulcer, closer view, and then it's sidal positive. So it shows that it's already perforated. Although you see, because of the necrosis and the mucus and tissue, kind of accumulated to that area, and it's elevated there. And so this kid presented with conjunctival xerosis, keratopathy, corneal ulcer, and perforated desmatocyst. And in our differential diagnosis, because of that xerosis, this is not a difficult case to diagnose vitamin A deficiency. Also, other differentials might be, hereditary autonomic dysfunction syndrome, or, just the infectious keratitis, or any other form of severe dry eye that we may see. But then, at that time, we glue it and put a contact lens. And again, you can see how much the conj is basically dry, and the xerosis that we see here, it's quite significant. And then we did the, basically the kid was admitted to the hospital. Workup started, genetic consult, and vitamin A level was sent, and the treatment with the oral vitamin A is already started. And then the lab that came back significant, the kid had significant anemia. Also, the corneal culture grew Streptococcus aeruginosus. That's a kind of saprophytic bacteria. It's mainly is not a kind of virulent bacteria. And then look at the vitamin A level, 2 microgram, and the normal level is 20 to 62. And also, soot chloride test is significantly elevated that confirmed the cystic fibrosis, and also this diagnosis confirmed later on by genetic testing that this is a cystic fibrosis. And cystic fibrosis is one of those diseases because of the significant malabsorption of all fat soluble. Actually, basically this patient, they have significant malabsorption, and particularly fat and fat soluble vitamins. And you see here, these patients with vitamin A deficiency, they responded very, very quickly. And this is about 5 weeks after the treatment. The contact lens was removed, the glue was peeled off, and already the hole closed here. And you see that shiny appearance disappeared. And this is the other eye. And I'm going to show you side by side how changes happen within 5 weeks of treatment with oral vitamin A. But this is the classic form of vitamin A. Even this kid presented with the classic form. We see everything. Also, this kid was not at the age that tells us that had a night blindness, and then conj xerosis and corneal xerosis, and then keratomalacia and ulceration. But we see at least conj xerosis, corneal xerosis, and ulceration. We see all these things together, and the diagnosis is very obvious. So this is the classic form that also in the places that they have nutritional deficiency, we see very often in this category. And this kind of things happen gradually, particularly in the, East Asia and Sub-Saharan Africa, that the cases associated with the nutritional deficiency, we see this type of classic form of vitamin A deficiency. So this is the classic form that we see the xerophtalmia, the classic xerophtalmia, and if we bring those WHO grading, we see some of those precursors of the more advanced form of the disease manifestation. But I'm seeing, and actually I haven't seen this explained this way, and this is mainly because of the cases that I have seen the past years, and I encountered completely different cases that I call them non-classical form of vitamin A deficiency. And probably if I call those cases as a chronic vitamin A deficiency, probably I would also call these are as a acute or subacute vitamin A deficiency, or non-xerophthalmic vitamin A deficiency, because we don't see this classic xerosis of the conjunctival and the cornea. The patient presented just with the corneal epithelial defect, corneal ulceration, corneal basically melting, and we don't see those classic stages of the disease. And this form of vitamin A deficiency can be easily missed. And I'm gonna present a few cases of this form. And these are mainly seen patients with alcoholism, hepatitis C mainly, or sometimes with hep B, and other form of hepatitis, or patients that has an end-stage liver disease and candidate for liver transplant. And also, most of these patients, they have other contributing factors, psychosocial factors that aggravate this basically vitamin A deficiency. And these cases, as I mentioned, because the storage area for the vitamin A is liver, and because they already have a damaged liver with a smaller storage area. And then they get another hit with something else. For example, they get more alcohol. They suddenly stop eating. And within a few days or weeks, they get a very severe form of deficiency because their vitamin A reserve was low to begin with. And this is the reason that they got a very acute form of the vitamin A deficiency. And they go directly to the corneal manifestation. So a case, and you can stop me anytime, and I can discuss these cases with you further. This is a case, 57-year-old male with significant psychosocial history, homeless, depression, alcoholism, and also had a treated history of syphilis, hypertension, diabetes mellitus. Actually, he presented to the ED because of decreased vision, and the resident that saw the patient, they saw that the patient has a Brunison cataract, more in the right eye than the hand motion vision in the right eye, counting finger vision in the left eye. And they send the patient to cataract clinic for, send basically patient presented to the emergency, but then they send the patient to the clinic for cataract evaluation and surgery. And when I saw the patient, I saw, also this patient, I saw the xerosis, the corneal xerosis, and significant dry eye. And I don't have any picture of this patient, but a few other things that guide me that this patient has vitamin A deficiency. The patient, because he presented to the ED, they checked him for the CBC and CMP. I noticed that the hemoglobin is low, and total protein albumin was okay, but magnesium was low. Phosphorus also low, although this we can see with alcoholism, and also magnesium we see with alcoholism. But I will show you in other cases why I'm going through these things. And we checked this guy vitamin A level, and it came back 17.9. It's kind of borderline vitamin A deficiency. This is one of those cases that if we miss and we don't treat them, the next time that he presented, he's going to present it with a corneal ulcer or total corneal melt. The next case that I want to present to you is a 31-year-old young guy came to the hospital because he was in the waiting list for liver transplant. He has a chronic alcoholic liver disease with cirrhosis. And he presented to us as well with a non-healing total epithelial corneal defect in the left eye. But he denies night blindness, and there is no other symptoms of vitamin A deficiency. This picture is not very sharp, but you see the right eye, you see the icterus, the patient has advanced liver disease, you see the jaundice, and then this eye, you don't see that xerosis. The conj is very looking normal. And this eye also is injected, and you see a total epithelial defect that I'm going to show you here. You see about 1 to 2 millimeter epithelium intact to the limbus. And this is usually the case that if the epithelium is slough, usually it stops around 1 to 2 millimeter to the limbus. But look how round shaped, like a neurotrophic epithelial defect. And because of, again, this patient had tons of lab work. And I look at the lab, he had hemoglobin, and he was alcoholic. Hemoglobin low, total protein low, albumin low, magnesium low. Phosphorus was actually is interestingly high, but if you look at the patients that they have high bilirubin, they give us a pseudo hyperphosphatemia. It says basically is a kind of lab error. So we're gonna forget about this. And I'm not that much emphasizing on the phosphorus, but I'm emphasizing the albumin, the magnesium, hemoglobin. And also, you see, the alcoholic patient, they have other vitamins low, but they usually, because when they presented, they get the supplement for vitamin B12 and folate. And you see they have enough of this. But we checked the vitamin A level for this patient. It's 10.7. It's very low. And also we checked the vitamin D level. Any fat soluble vitamin can be affected. So, and this patient actually went through, this patient actually had a very, very long history. I don't want to go over the things. He get through the liver transplant and went through lots of, sepsis and other, multi-organ failure. And eventually, we try to treat him with the oral, because, the problem with this case, the best course of action is to give him the parenteral form of vitamin A. And parenteral form of vitamin A is not easily available in the United States. And they try to give this patient oral form. And the oral form, a patient that, went through the surgery and then in ICU, also had a, G-tube, but it's quite difficult to give with all other things that the patient went through. They couldn't supplement his body with the vitamin A that he needs. So it took forever that that epithelium become closed, and eventually he ended up with a scar on the cornea in that eye. The other case is a 28-year-old male with alcoholic cirrhosis.
Dr. Dastjerdi, before we
yes.
do have one question, if you want to.
Okay. Okay.
Between cases. The question is, will a dexamethasone from vitamin A deficiency sometimes heal with vitamin A supplementation? Or are those patients always going to require a cornea transplant?
It depends on the size of the ulcer and perforation or desmatocele. If it's, that kid that I showed you, the ulcer was small, and we just glue it, and it healed with the, glue, contact lens, and vitamin A supplementation. But when the desmatocele is large, that we can't, because desmatocele, the surgical plan always, if it's a small area, okay, we can glue it. But when it's big, we need to do tectonic transplant. And I have a few cases that I can show you that they presented with total corneal melt, and I did the tectonic transplant, and plus with vitamin A supplementation. No, the desmatocele, the tissue, when with the keratomalacia, when the corneal tissue gets lost, it's gone. It's not going to replace The only way that we can medically manage them or non-surgically manage them, if it's a small, that, like any other corneal perforation, that if it's a small, we can manage it non-surgically with glue and contact lens. But here, the main point, besides the things that we do with surgically, we need to supplement them with the cornea, with the vitamin A. Otherwise, again, that ulceration or, keratomalacia going to come back on the corneal transplant. And I have a case that I'm going to present to you as well here.
I have one more question if you want to answer it now that just came through, I think referring to each of the cases where you checked vitamin levels. And the question is, do you check vitamin A precursor levels, such as keratin, when checking vitamin levels in these patients where you suspect deficiency?
As much as I know, I don't know the details of the lab, how they checked it, but I know that they checked the retinol form of the alcohol form of the vitamin, basically the one that we call vitamin A, because vitamin A is in different forms, in the aldehyde form, is in the alcohol form, in the ester form. The one is active is the alcohol, retinol. They check the retinol. And they do this measurement. And one thing with the measurement, make sure if you are sending a patient for vitamin A level, make sure patient doesn't start the vitamin A orally, because as soon as they get one dose of the oral and they go there, it's falsely elevated. We need to get the vitamin A level first, and even a multivitamin that has 2,500 units, very small amount of vitamin A. If the patient takes a multivitamin, it may falsely give us basically normal level of the vitamin A. That's the only thing that I know, that when I send the patient, I ask them not to get the vitamin A supplementation till they draw the blood, and then they can start the vitamin A.
Great, thank you. I just wanted to get those questions about the first couple cases and go on to case 4.
Okay, let me go to this next case. Again, another one, alcoholic cirrhosis, admitted for liver transplant. The reason that we have too many liver transplant surgery, because our center is a liver transplant center. So I encounter this patient more often than many other people. But again, this patient, while in the hospital, waiting for other things to get prepared for the transplant surgery, he developed basically irritation, redness, and blurry vision in the right eye. And then we noticed a large central epithelial defect, just purely epithelial defect in one eye, and the other eye has a diffuse epitheliopathy without epidefect. And again, because of that, when we consulted, and because of the history, the alcoholic cirrhosis, and also look at the lab, what we have for him. Also, this one, sorry, I couldn't get the lab for him, but I'm sure I have one. But for this one also, we checked the vitamin A, and it's 14.9. Again, it's very low. We have another case, a 71-year-old female admitted for alcoholic cirrhosis and liver failure, again for liver transplant. And this one presented with dendritic epithelial ulcer. The resident called me, actually, we were consulting over the weekend, and I remember this case that they called me that this patient has a herpetic ulcer because it's a very classic dendritic. And when they gave me this history that the patient is alcoholic cirrhosis admitted for the liver transplant, and I told them, okay, just check for, you can start the antiviral, but check for the vitamin A and start the patient on vitamin A. And then this patient, unfortunately, the next week, she went for the surgery, liver transplant. And at the beginning of the surgery, she got complete heart block, and they stopped the surgery. And then a few days later, she passed away. But look at the lab for her. Again, if you look low hemoglobin, low protein, total protein, low albumin, low magnesium. Again, phosphorus is elevated a little bit, but we checked the vitamin A. It's 4.8 for this case. And vitamin D also is quite low. So again, this case, probably, I'm not saying that that patient, we didn't check for the PCR for HSV. The classic presentation was dendritic ulcer. But at the same time, because we know about the history and also that lab that already available to us, I was highly suspicious that this patient is vitamin A deficient. And if I want to treat this epithelial defect and ulcer, besides that antiviral, I will supplement. We already actually started on vitamin A supplementation. And this case, again, interesting case with a history of infectious endocarditis, asthma, diabetes, lupus, Hep C, opioid use disorder, alcohol use disorder. You see that's, the history. And again, transfer of corneal ulcer and melt. Actually, they transferred from a different hospital to her. And she underwent, because was a large, basically, perforation. And we did a tectonic PKP the same day. But also I checked, she had a limbus to limbus corneal melt with prolapse of uval tissue, but no sign of infection. And the other eye, no obvious sign of significant ocular surface disease in the fellow eye. When you look at the other eye, you don't see any sign of xerosis. You think that if this patient has a limbus to limbus melt and no sign of infection, and young lady, okay, and also she has other issue as well. But the other eye doesn't have any sign of ocular surface. And then we checked again, if you look at, also his hemoglobin is borderline okay, albumin is low, calcium is low. Again, this one, phosphorus is low, magnesium is borderline. And then again, vitamin A was 2.5. She had a severe form of vitamin A deficiency. And this is the one that I want to say that this patient had an acute form of vitamin A deficiency. She didn't went through all those stages. She went directly with ulceration and a few days with melt and perforation. And this is a case that if we look at the things, probably, patient had all this disease, liver disease. Her storage area is already shrunken significantly. And then another hit, whatever she does, she's addict to, multi-drug abuser, other social issue. And one thing quickly can basically push her to a very severe form and, acute form of vitamin A deficiency. And this is the last case that I just want to quickly go over and then give you a few slides of my own conclusion. That what's my recommendation now for these patients. This is an interesting case. Again, 58-year-old female with alcoholic hepatitis and hepatic encephalopathy and many other things. She came to and admitted to the hospital because of the basically peritonitis. And then we were consulted that the patient has an ulcer in the eye, and she had a central corneal ulcer about 1.5 millimeter with hypopyon. The fellow eye was quite unremarkable. And then culture grew just P. acne. Although the patient had hypopyon, although I, sometimes consider that P. acne might be just a contamination, but still, or any other, bacterial agent that caused this. But this patient, eventually that ulcer didn't heal, and it become, and this is one of those first patients that I deal with. And initially I didn't go after vitamin A deficiency, and we just tried to treat this infectious corneal ulcer with the fortified antibiotic. And it didn't respond and eventually perforated. And I did the first tectonic transplant. And then I went basically, this is something that now that I go back and I look at the labs, I didn't pay attention to these things to the lab in the beginning. Her hemoglobin was low, total proteins low, albumin was low, magnesium low, phosphorus low. And then when we checked the vitamin A, it was 10.6 and vitamin D level was 7. And this patient, after the first transplant, we started on oral vitamin A. Also, oral vitamin A, again, is a big issue with the patient with malabsorption. Probably the best course of action is to give them the parenteral form of the vitamin A that's not available or is not easily available to get it. And this patient actually, look at her vitamin A level. 12.6, 19.6, probably that was, and then again, it was not, even after a few months of treatment, it didn't get to the level that is sufficient. And eventually, and again, after the transplant, it became ulcerated and I need to do another transplant for her. And eventually, after quite a while, vitamin A supplementation, her vitamin A level get to that 28 microgram. And for the treatment, quickly, if we have the injection form, that is very difficult to get that. It comes in 50,000 units per ml. And for any vitamin A deficiency with xerophtalmia or corneal keratomalacia, it's 100,000 units intramuscular for 3 days, then 50,000 units every day for 14 days. And then we need to continue with oral vitamin A, 10,000 to 20,000 units for up to 2 months. But this is not available. And we go with the oral vitamin. And as I mentioned, to most of these patients, they have difficulty with absorption. So probably we may need to go or continue for much longer treatment. Again, treatment, and it's available at 8,000. The vitamin A in multivitamin is 2,500, but we have pills and capsules available with 8,000, 10,000, 15,000, and 25,000 units. And again, the first treatment is 100,000 units PO every day for 3 days, then 50,000 units for 14 days, and then 10,000 to 20,000 every day for up to 2 months. And this is my last, two last slides, that's my conclusion. So these cases suggest that vitamin A deficiency should be investigated in all patients with severe liver disease, alcoholism, hepatitis C, B, immune hepatitis, alcoholic and non-alcoholic cirrhosis, and end-stage liver disease, and any patient that is candidate for liver transplant, even before they presented with any ocular symptom. We need to check them for vitamin A deficiency. The other thing, also, a patient that presented with corneal ulcer without any known risk factor, you look for risk factor, because always when we have an infectious corneal ulcer, we're looking for some risk factor, contact lens wearer, injury, dry eye, exposure, or whatever, and we don't find anything. There is no known risk factor. And patients that they have some kind of unusual psychosocial characteristics, homelessness, addiction, elderly individuals, or people that they living in the nursing homes, they also should be, besides the classic treatment that we do with the corneal ulcer, they need to be checked for vitamin A deficiency. And also patients who have a corneal ulcer at the same time, you see the CBC and CMP, and most of these patients, they have kind of, this basic lab work already done. And you see a low level of hemoglobin, low level of total protein or albumin, low level of calcium or magnesium. Also, I would suggest to be evaluated for vitamin A deficiency. And thank you for your attention. I'm open to question. And yeah, it's almost 8 p.m. So I don't know if we can. If
Perfect
any
timing.
question. Mhm.
It's perfect timing. You ended right at 8 perfectly.
Okay.
And so, yeah, if anyone has any, we answered a couple of those questions about the first few cases that came through in the Q&A and chat earlier. So if anyone has any last minute questions, feel free to type them into the chat. I just want to say thank you so much, Dr. Dastjerdi, for the talk. It seems like although uncommon, vitamin A deficiency might be more common than
We think.
one might think. Yeah.
Yeah.
And as always, the webinar will be available online, the recording, in just a few days from now. When everyone logs out, you'll be prompted to take a survey. Please feel free to give us any feedback that you might have. And it looks like we just had one more. Just a couple comments in the chat. Thanking you for the talk. And one question, would cod liver oil be useful in the treatment of vitamin A deficiency?
Yes, but I would say cod liver is okay to prevent the vitamin A deficiency, not for the treatment. For the treatment, we need to go with, high doses, right? Cod liver oil has at this, probably 2 to 3 times of multivitamin pill, the level of the vitamin A on cod liver. So then the amount is not enough. And remember, when we diagnose a patient with vitamin A deficiency, the dosage is quite high. But cod liver oil is good in these patients. If you have a patient with liver disease, we can suggest to them, okay, if you want to prevent vitamin A deficiency, you can get cod liver oil, or you can get green leafy vegetable, or meat, eggs, this kind of thing. They have quite enriched in vitamin A. But again, I don't think it's enough for treatment, but it might be good for the prevention.
Thank you. There's one more question if you have a minute to hang out.
Yes, sure.
Dr. Dastjerdi. And so this is a question about a specific case. So I recently had a patient with classic xerophthalmia with corneal scarring, already with epithelial defect. Vitamin A was very low, and interestingly, vitamin C was also very low. We know vitamin C may help prevent melting in chemical burns, other situations. And so the question is, have you looked at vitamin C levels in these patients?
Actually, no. I never checked for the vitamin A, and actually, because vitamin C, is for all corneal ulcers or any patient with, persistent epithelial defect or any, chronic keratopathy. Vitamin C is part of the treatment. I always give the patient high level of vitamin C, and vitamin C is because it's water soluble and it's quickly absorbed through the body. And I gave them 1 to 2 grams a day till the cornea, the ulcer, the epithelial defect get healed. So, and because it's, it's already started, most of these patients that came with the corneal ulcer, when they presented to the emergency as a routine or resident, they start them on doxycycline and vitamin C as a supplementation to augment the healing process besides the fortified antibiotics. So they already got the vitamin C, and might be, all these patients, might be, as I mentioned, they might be deficient in many other micronutrients, zinc, also other water-soluble vitamins as well. But I never checked the vitamin C.
I'm muted now. No, I'm not. Do you have time for one last question?
Sure.
So this is from one of our friends in Australia. Are you aware if B12 deficiency has any effect on the cornea, specifically the endothelium or stroma?
No, I'm not aware, but these patients, they may be B12 deficient as well. But the good thing, you know, one thing with this alcoholic patient, when they get to the emergency, always they get that banana bag, and banana bag always it's filled with all the vitamin B. Basically, it has everything. And when we checked, actually, you know, if you look at those cases that I presented, their vitamin B12 level and folic acid, they much higher than the normal level that should be. And that shows that this patient, when they go to the emergency, they already get the banana bag. And that's the reason that, you know, people pay attention to those vitamin B group, but they don't pay attention to D and A or fat soluble vitamins. You know, the other thing that also I'm interested, vitamin E is the other thing that probably some of these patients at some point we need to look into this and see what's the, you know, if this vitamin E also might be factored in. But definitely A, we know, D, we know. K, already most of these patients, they have some bleeding things, and we know that the vitamin K also is deficient. Vitamin E, I'm sure it can be deficient in this patient, but I don't know the importance of it in the basically in ocular surface and cornea particularly.
Well, great. It looks like that is the end of the questions for tonight. And thank you everyone for your questions. And especially thank you to Dr. Dastjerdi for giving this talk tonight. And so we'll hope you'll all join us in February. And again, check the survey as you're logging out of the webinar and give us any feedback that you might have. And see you all next month.
Have a good night, everybody. Thank you.
Thank you. Bye-bye.
Bye now.